Okay, so we're going to go ahead and get started. Hello and welcome to our webinar. Today we're going to be presenting on the dangers of EHR blocking and its effect on interoperability. This is the third webinar in our four-part Government Regulations and Ramification Series. My name is Chelsea Grover and I'm the Marketing Communications Coordinator for ITENIV. I'd like to take a moment to explain the process for today's presentation. First, I'd like to mention that this webinar will be recorded. Next, I'm pleased to announce the date for our final webinar in this Government Regulations and Ramification Series. It's on high-tech security and HIPAA on December 16th. In it, we will focus on the privacy and security of patient health information and on exploring compliance tools and features that help guard against unwanted breaches. Through it, you will learn what you need to know how to keep your practice safe. Okay, so back to this webinar. At the end of the presentation, we will open the floor up to questions from you. We will answer all the questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. For your reference, we will also be emailing out links to the recordings and PDF of the presentation later this week, as we do with every webinar, and all of our past webinars are available on our website. Finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today, Lindsay Lanning and Jeannie Logue. Lindsay originally joined us from the Ohio State University intern program while she was getting her degree in Health Information Management Systems. After graduation, Lindsay joined our team as the Healthcare Informatics Coordinator, where she spends her time immersing herself in the ever-changing healthcare IT environment and educating the rest of the company on new issues and trends in the industry. Lindsay will be leading today's webinar. Jeannie Logue has been in the industry for over 25 years and is the Director of Consulting Solutions at ITENIV and is one of the leading experts. You have likely heard her speak before, either on previous webinars or in person at UGMs and MGMAs. She has worked here for 13 years and lives and breathes the industry and travels across the country seemingly nonstop working with our clients at their locations. She is the NextGen expert and will be here to help answer questions at the end. And sorry, Jeannie, I misspoke your title. You're actually the Director of Management Consulting. Okay, so Lindsay, I'm going to go ahead and pass the webinar off to you. Feel free to get started when you're ready.
Great, thank you, Chelsea. Hi, everybody, and welcome. Thank you for taking time out of your busy week to sit on this webinar regarding the dangers of information blocking and its effects on interoperability. In this webinar, we're going to first be focusing on the basics of interoperability by covering the different levels and key challenges that go along with this initiative to get everyone connected and sharing data. We will then look at the largest threat to interoperability, which has gained a lot of attention recently, and that is information blocking. This issue has not only caught the eye of ITENIV, but has made its way to Congress as well. Information blocking has become a subject matter of concern for almost every government healthcare agency this year. It truly is the latest and greatest stressor in the healthcare industry. But what is it? Who's committing it? And who's falling victim to it? No one seems to be providing concrete answers to these crucial questions. All we know is Congress is angry, providers are angry, and unknowing patients should be angry. This webinar will hopefully provide answers to all of these questions and more, but let's start off by looking at how interoperability is defined. So I provided two definitions, one by the Health Information Management and Systems Society, or HIMSS, and the other by the American Health Information Management Association, or AHIMA. HIMSS says, interoperability describes the extent to which systems and devices can exchange data and interpret that shared data. For two systems to be interoperable, they must be able to exchange data and subsequently present that data such that it can be understood by a user. And AHIMA says, interoperability is the ability of different information technology systems and software applications to communicate, to exchange data accurately, effectively, and consistently, and to use the information that has been exchanged. Both definitions address the exchange of data, but HIMSS goes further, making sure to point out the ability to interpret data is also key to interoperability. I think AHIMA is alluding to that when they use the word communication, but I do like how HIMSS expressly says it's not just about the exchange, but also about the ability to interpret. So overall, interoperability refers to a healthcare system's ability to connect with other systems. Basic interoperability is the sharing of data, and advanced interoperability includes uniform presentation of healthcare data, uniform user controls, and uniform protection of patient confidentiality. This spectrum from basic to advanced interoperability can be broken down into three distinct levels. And according to the HIMSS board, these 3 levels of interoperability are foundational, structural, and semantic. Foundational interoperability allows data exchange from one information technology system to be received by another and does not require the ability for the receiving information technology system to interpret the data. Structural interoperability is an intermediate level that defines the structure or format of data exchange, i.e. the message format standards, where there's uniform movement of healthcare data from one system to another, such that the clinical or operational purpose and meaning of the data is preserved and unaltered. Structural interoperability defines the syntax of the data exchange. It ensures that data exchanges between information technology systems can be interpreted at the data field level. Semantic interoperability provides interoperability at the highest level, which is the ability of 2 or more systems to exchange information and to use the information that has been exchanged. Semantic interoperability takes advantage of both the structuring of the data exchange and the codification of the data, including vocabulary so that the receiving information technology system can interpret that data. This level of interoperability supports the electronic exchange of patient summary information among caregivers and other authorized parties via potentially disparate electronic health record systems and other systems to improve quality, safety, and efficiency of healthcare delivery. So why is interoperability important? EHR system interoperability is a necessary step toward transforming healthcare into a system that can achieve goals of improved quality, efficiency, and patient safety. For example, use of interoperable EHR systems could better enable healthcare providers to view results from diagnostic procedures conducted by other providers to avoid duplication, evaluate test results and treatment outcomes over time, regardless of where the care was provided, to better understand the patient's medical history, share a basic set of patient information with specialists during referrals, and receive updated information after the patient's visit with the specialist to improve care coordination, view complete medication lists to reduce the chance of duplicate therapy, drug interactions, medication abuse, and other adverse drug events, and identify important information, such as allergies or pre-existing conditions, for unfamiliar patients during emergency treatment to reduce the risk of adverse events. The most valued patient data resides in the EHR, yet EHRs are architected to perpetuate data silos. Because of the lack of interoperability, healthcare providers can't achieve true care coordination. The rapid expansion of value-based reimbursement is exposing unmet needs for active coordination, not only for care, but financially and administrative as well, within and between healthcare organizations. Data sharing is needed to make vital assessments and deliver high-quality care. And this is why achieving interoperability is becoming one of the nation's top healthcare goals. So what's stopping this from happening? Let's look at the key challenges related to interoperability. Key challenges related to interoperability were identified by the Government Accountability Office's report titled Non-Federal Efforts to Help Achieve Health Information Interoperability. This report, released on September 29th, details the 5 main barriers to interoperability. The first being a lack of mandated health data standards. While standards for electronically exchanging information among EHR systems exist, stakeholders have said that these standards are not sufficient for achieving EHR interoperability. This challenge stems from the fact that some standards are not specific enough, and as a result, the systems that implement these standards may not be interoperable. According to some stakeholders, some standards allow EHR systems to use different formats and terminology when exchanging data. However, this resulting variability prevents the receiving system from processing the information and properly integrating it into the patient record. In other words, the systems are not interoperable. Information that is electronically exchanged from one provider to another must adhere to the same standards, and these standards must be implemented uniformly in order for the information to be interpreted and used in EHRs, thereby enabling interoperability. The second challenge is differing state privacy laws. Stakeholders and initiative representatives said that exchanging health information with providers in other states, which is necessary for nationwide EHR interoperability, can be difficult. This challenge exists because of variations in privacy rules from state to state, especially variation in laws pertaining to patient consent for sharing health information. Another key challenge to EHR interoperability is accurately matching patients' health records that are stored in different systems. This challenge exists because many EHR systems use demographic information, such as a patient's name and date of birth, to match different health records for a given patient held by different providers. Demographic variables do not always yield accurate results because, for example, there could be more than one patient with the same information. In addition, providers may not collect and use the same demographic variables for matching. Costs associated with achieving interoperability can also be prohibitive for providers. This challenge exists in part because of the high cost of EHR customization and legal fees associated with interoperability. Stakeholders also said that it can be challenging to establish the governance and trust among entities that are needed to achieve interoperability. These governance practices can include organizational policies related to privacy, information security, data use, technical standards, and other issues that affect the exchange of information across organizational boundaries. And finally, although not identified by the GAO's report, we all know a major challenge to interoperability is information blocking, which we will go into much more detail about later. The underlying problem here is EHRs don't talk to each other very well. A complex healthcare system requires diverse electronic health record products, and the architecture or standards that make it possible for diverse EHR systems to work compatibly in a true information network is what is needed. So these health data standards that are needed are technical requirements used to facilitate health information exchange and interoperability of systems, including EHR systems. Such standards consist of terminology and technical specifications that, when adopted by multiple entities, facilitate the exchange and interoperability of health information. Standards define how information is packaged and communicated from one entity to another, setting the language, the structure, and data types required for the integration between systems. A standard provides the fundamental definitions for and structures of the data that can be communicated across a wide variety of use cases. Examples of standards include Health Level 7, or HL7, Systemized Nomenclature of Medicine, or SNOMED, Logical Observation Identifiers, Names, and Codes, or LOINC, just to name a few that you may be familiar with. But standards take time to develop. They must be implemented and tested, and implementation specifications are as important as the standards themselves. And the announcement of new standards before existing standards can even be implemented and tested delays the progress even more. But this lack of mandated standards isn't the biggest issue facing interoperability. Information blocking is. Information blocking can be described as the basic refusal to exchange patient information with others. The purpose of electronic health records was to make care coordination an actuality between physicians and EHR systems. It was also to make the transfer of health information possible and make the patient experience better and safer. Each time you walk into a doctor's office, the reality should be that all your health information is readily accessible by your provider, regardless of where you receive the care. This is incredibly important because it affects the quality of your care on a very real level. I'm hopeful that this issue will be non-existent very soon, but for now it's important we understand what information blocking is and how to prevent it. So information blocking occurs when persons or entities knowingly and unreasonably interfere with the exchange or use of electronic health information. This definition requires 3 criteria to be met. The first is interference. Information blocking requires some act or course of conduct that interferes with the ability of authorized persons to access or use electronic health information. This interference can take many forms, from express policies that prohibit sharing information to more subtle business, technical, or organizational practices that make doing so more costly or difficult. The second is knowledge. The decision to engage in information blocking must be made knowingly. An individual or entity does not engage in information blocking unless it knows, or should know under the circumstances, that its conduct is likely to interfere with the exchange or use of electronic health information. Now, don't let this aspect trick you into thinking that you can claim, I didn't know what it was, so I couldn't have been committing it. With the amount of information and reports released by the government this year, everyone should know what constitutes information blocking. And finally, no reasonable justification. Not all conduct that knowingly interferes with electronic health information exchange is information blocking. Accusations of information blocking are serious and should be reserved for conduct that is objectively unreasonable in the light of public policy. Public policy must be balanced to advance important interests, including furthering the availability of health information as needed for authorized purposes, protecting and promoting patient safety, maintaining the privacy and security of electronic health information, and protecting innovation that ultimately enhances technology, healthcare, and consumer health and welfare. Basically, this means to commit information blocking, there needs to be an act of data sharing interference done on purpose with no reasonable justification for it. And reasonable justification would be like preventing the exchange of data for privacy or security reasons that would protect a patient. To clarify, let's look at other barriers to interoperability that are not necessarily information blocking. A major barrier to effective sharing is the lack of coordination among many persons and entities that participate in or facilitate health information exchange. These coordination problems often stem from technical or practical challenges that are beyond the control of any individual actor. As a result, persons or entities may implement technical standards in inconsistent ways, adopt divergent privacy, security, or trust policies that govern how electronic health information is exchanged and used, or engage in other inefficient behaviors that inhibit or reduce opportunities to exchange and use electronic health information to improve care. In general, these inefficient and uncoordinated behaviors do not raise information blocking concerns because they result not from a knowing and unreasonable interference, but from larger systemic barriers to interoperability. Let's look now at this figure that shows the prevalence of other barriers to interoperability from a 2014 provider survey. The three types of barriers identified were technical, operational, and financial. You can see the majority of barriers were due to technical issues, the highest of which were actually due to the exchange partner system deficiencies and not their own system issues, with the next highest barrier being finding the provider address, which directly leads into the operational barrier of a complex workflow. I think this serves as a great high-level visual of what is standing in the way of a complete care coordination for patients today. So now that we know what information blocking is and have compared it to other barriers to interoperability, let's look at practices likely to cause information blocking. Because of their inherent potential to interfere with health information exchange, these practices, when undertaken knowingly and without a reasonable justification, constitute information blocking. And they are contract terms, policies, or other business or organizational practices that restrict the exchange or use of information from treatment and other permitted purposes. Charging prices or fees, such as for data exchange, portability, and interfaces that make exchanging and using electronic health information cost prohibitive. Developing or implementing health IT in non-standard ways that are likely to substantially increase the cost, complexity, or burden of sharing health information. And developing or implementing health IT in ways that are likely to lock in users or electronic health information, lead to fraud, waste, or abuse, or impede innovations and advancements in health information exchange and health IT-enabled care delivery. So now that you're aware of the practices likely to cause information blocking, let's look at what complaints regarding information blocking sound like. Well, most complaints of information blocking are directed at health IT developers. Many of these complaints allege that developers charge fees that make it cost prohibitive for most customers to send, receive, or export electronic health information stored in EHRs, or to establish interfaces that enable such information to be exchanged with other providers. Some EHR developers allegedly charge a substantial per transaction fee each time a user sends, receives, or searches for a patient's electronic health information. EHR developers may also charge comparatively high prices to establish certain common types of interfaces, such as connections to local labs and hospitals. Many providers also complain about the cost of extracting data from their EHR systems for their own use or to move to a different EHR technology. And finally, there are complaints of restricting users of a developer's technology from exchanging health information with users of a competing technology or service. Developers either prohibit or make it unnecessarily difficult or expensive for their customers to connect to third-party health IT modules, even when these modules have been certified by ONC and would enable customers to connect and share electronic health information with a wider network of providers and other exchange partners. So what can we do to prevent this from happening? We can limit standards and implementation specifications. Although there is uniform criteria in place, there is still a substantial amount of variability in the underlying required standards, unique clinical workflow implementations, and numerous types of interfaces to connect multiple systems. This variability has contributed to information sharing challenges and also creates opportunities for developers or health IT implementers to erect unnecessary technical barriers to interoperability and electronic health information exchange. We can also promote greater transparency in certified health IT products. One of the most effective ways to reduce information blocking is to promote transparency in the health IT marketplace. Providing customers with more reliable and complete information in health IT products and services would make developers more responsive to customer demands and help prevent developers from engaging in behavior that raises serious information blocking concerns. We should also be taking action to establish governance rules that deter information blocking. Many types of information blocking could be mitigated by requiring everyone to adhere to certain basic expectations related to the availability and sharing of information for purposes of patient care. Two principles that will be adhered to regarding trust and interoperability among providers and developers will be shared protected health information, so entities that hold data or facilitate exchange would be expected to adhere to the principle that discourages them from erecting unnecessary policy, business, operational, or technical barriers to information sharing for patient care, care coordination, and other purposes that are consistent with applicable law, professional ethical standards, and patient preferences. And second, open exchange. Entities that facilitate exchange would be held to an expectation of neutrality and discouraged from erecting barriers to information sharing based solely on favoritism toward a specific business partner. We need to work with HHS to improve understanding of HIPAA in regards to information sharing. Efforts will be made to improve health IT stakeholders' understanding of the HIPAA rules and how they support interoperable exchange by permitting disclosures of protected health information for treatment, payment, and healthcare operations. To achieve interoperability, all entities regulated by HIPAA rules must understand the circumstances under which the rules permit the sharing of PHI. We must find ways to promote competition and innovation in health IT and healthcare. The goals of advancing health information exchange and promoting competition and innovation are broadly compatible and will in most cases be aligned. FCC has acquired deep expertise in health IT markets and competition, which enables it to provide valuable guidance to ONC as it formulates market-based policies and approaches to advance interoperability and exchange. And finally, we need to be looking for ways to reward interoperability. Evolving healthcare payment from a volume to value-based system could play a significant role in preventing information blocking. Providers paid primarily on a fee-for-service basis have incentives not to exchange electronic health information outside their organizations because increased coordination of care can result in reduced volume of billable services, including duplicate and inappropriate services. Under the new value-based payment programs, however, providers are increasingly reimbursed based on the health outcomes of individuals and the degree to which providers can reduce the total cost of care while improving healthcare quality and the patient experience. But there are limitations in preventing information blocking. Identifying information blocking is a difficult and highly fact-specific task that requires access to detailed and often sensitive information about provider or developer business, technical, and organizational practices. ONC has no authority to require providers to produce relevant information, such as contracts with developers, and may have a limited ability to require developers to produce this information outside the context of the ONC HIT certification program. ONC cannot take direct action against providers who block information, and current conditions of participation in federal healthcare programs do not specifically prohibit information blocking. ONC will coordinate within HHS and with other federal agencies to explore whether creating and enforcing conditions of participation against information blocking would be feasible under these programs. And finally, most information blocking does not violate any current provisions of the law. As a result, investigation and enforcement of information blocking is largely incidental and not responsive in a comprehensive manner. The precise nature and extent of information blocking remains unknown. However, based on the evidence and knowledge available, it is apparent that some healthcare providers and health IT developers are knowingly interfering with the exchange or use of electronic health information in ways that limit its availability and use. These limitations to preventing information blocking are what led Congress to urge the ONC and other healthcare organizations to address this issue in some way. So let's look at the government's focus on interoperability and information blocking. The Senate Health Education, Labor, and Pensions Committee has made interoperability their #1 priority. In July 2015, the Senate Healthcare Committee conducted a hearing titled Achieving the Promise of Health Information Technology, Information Blocking and Potential Solutions. The Senate Committee continued with more hearings on the subject to probe for answers on details and the scope of this problem. Specifically, on September 16, 2015, the Health Committee held a hearing on improving interoperability, calling on Congress to create standards and advance health data sharing. And again, on October 1, 2015, the Health Senate Committee held a hearing on the promise of health IT, where they urged the ONC to fast-track the impending release of its roadmap to address the technical standards, certification requirements, privacy and security standards, and other initiatives that will enable true HIT interoperability. Discussion among senators during these hearings focused on the extent to which health information blocking is or isn't occurring, and what actions the federal government could take to put an end to such practices while still encouraging interoperability. Meanwhile, the House passed the 21st Century Cures Act in July, which includes a section titled Ensuring Interoperability of Health Information Technology, which seeks to improve the interoperability of EHRs and stop information blocking. The bill defines interoperable health IT, improves the standard setting process, creates new certification requirements, defines information blocking, creates new enforcement mechanisms, and creates an HHS vendor compare website. The SGR repeal, or MACRA law, also recently passed, includes an interoperability section titled Promoting Interoperability of Electronic Health Record Systems. The section declares it a national objective to achieve widespread exchange of health information through interoperable certified EHR technology nationwide by December 31st, 2018. It defines widespread interoperability and requires HHS to establish metrics to determine whether the national objective is met. If they determine that the objective has not been met by December 31st, 2018, it requires HHS to submit a plan to Congress that identifies how the government can support it. And finally, it also states that as a condition of meeting meaningful use, it would require an attestation that an EP or hospital has not knowingly and willingly taken action to restrict the compatibility or interoperability of the certified EHR technology. On October 6th, the final ONC Interoperability Roadmap was released. The roadmap outlines 3 broad components to achieving interoperability: an alignment of incentives, the necessary technical standards and implementation specifications, and the appropriate governance structures. The roadmap explains the ONC plan for achieving interoperability across the entire healthcare industry over the next decade. The roadmap is organized into 3 sections, starting first with drivers, which are the mechanisms that can help create a supportive payment and regulatory environment that deepens interoperability. The next section addresses policy and technical components, which are essential items stakeholders will need to implement in similar or compatible ways in order to enable interoperability. The last section addresses outcomes, which serve as the metrics by which stakeholders will measure our collective progress on implementing the roadmap. Each section includes specific milestones, calls to action, and commitments that will support the development of a nationwide interoperable health IT infrastructure. The document also describes near-term, mid-term, and long-term goals to advance the safe and secure exchange of electronic health information nationwide. Between 2015 and 2017, the ONC plans to increase sending, receiving, obtaining, and using health data across interoperable health IT systems. According to the federal agency, this should improve healthcare delivery via care quality and patient outcomes. Between 2018 and 2020, the ONC hopes to increase the number of clinical data sources and users in the interoperable system. This should also help improve healthcare delivery and presumably lower costs. The final step of the ONC roadmap is scheduled to take place between 2021 and 2024. The goal is to achieve nationwide interoperability with the person at the center of a system that can continuously improve care. The ONC released their draft of the 2016 Interoperability Standards Advisory this September. ONC uses the Interoperability Standards Advisory process to coordinate the identification, assessment, and determination of the best available interoperability standards and implementation specifications. So, although this is not a regulatory document, ONC will draw upon these standards when issuing other regulations in the future. The ONC also released an information blocking report at the request of Congress. This report details their findings on the extent and nature of health information blocking as determined by their analysis on this issue, gathered through complaints, anecdotes, empirical research, and discussions with industry sources gathered over the last year. This report was delivered in April and found that health information blocking occurs when persons or entities knowingly and unreasonably interfere with the exchange or use of electronic health information. And that from the evidence available, it is readily apparent that some providers and developers are engaging in information blocking, but that the full extent of information blocking is difficult to assess. The last thing we will talk about released by the ONC was the 2015 edition for CEHRT certification criteria with provisions regarding interoperability. The rule uses various strategies to improve interoperability and the transparency of health IT. To improve interoperability, ONC states that the certification rule will establish a mandatory standard for HIE, as well as an updated data export, facilitating better access and exchange of information. Specifically, it improves interoperability by adopting new and updated vocabulary and content standards for the structured recording and exchange of health information, including a common clinical dataset. On October 6, 2015, the OIG released a policy reminder titled Information Blocking and the Federal Anti-Kickback Statute. This special report was meant to remind industry stakeholders of information blocking and the Federal Anti-Kickback Statute relative to EHR adoption and use. The OIG warns EHR users of information blocking and consequences for preventing EHR interoperability. And finally, on October 2, 2015, a group of 12 leading EHR vendors agreed by consensus to objective measures of interoperability and ongoing reporting. These leaders proactively stepped forward to have an independent entity publish transparent measures of health information exchange that can serve as a basis for understanding our current position and future. Assisted by leading provider organizations and informatics experts, these leading EHR vendors, including NextGen, knocked down barriers to arrive at measures to improve interoperability for the public good. The proposed interoperability reports are based on information gleaned from healthcare providers about their own health information technology systems and includes both hardware and software information. For example, hardware data could come from providers checking off the types of interoperability they have achieved using a specific vendor system. The software questions, such as how responsive is this vendor to your interoperability needs, might seek out experiential types of information. The information gained from interoperability reports will yield real information about differences between vendors and provide insight as to how the market is moving. So how is all of this affecting NextGen clients? Is NextGen aware of information blocking, and what are they doing to combat it? Well, NextGen has released a statement saying, It is likely that as a condition of attesting for meaningful use in the future, physicians will have to attest that they are not information blocking. While the definition of this practice remains vague, electronic sharing of relevant patient information with physicians inside and outside your health system satisfies your meaningful use obligations in this respect while improving efficiency and coordination of care. NextGen Share makes it easy to securely exchange information with other providers and is the best way to prove you are not participating in information blocking. So yes, they are aware of it, and they have offered clients a solution to ensure they are not participating in information blocking. So let's take a look at that solution and how you can share healthcare information right now. In that statement we just heard from NextGen, they mentioned NextGen Share. And NextGen Share was built using NextGen and Mirth integration and provides secure connectivity between both NextGen Healthcare and non-NextGen Healthcare providers. It gives you access to a national provider network connecting all NextGen clients together and connecting NextGen clients to external systems as well. It also integrates referral ordering into your workflow and supports secure sharing of EHR documents. NextGen Share supports interoperability across all certified EHR vendors to enable the exchange of clinical information. It includes a searchable provider directory and message translation between supported formats. Providers can exchange clinical files, such as CCDA files and attachments, referral request letters, and intake notes. Access to these patient files and the ability to share them will improve patient safety and patient health outcomes across the network. NextGen Share is also DTAAP certified. The Direct Trust Agent Accreditation Program validates and supports compliance with the technical, security, trust, and business practices required for direct messaging. This certification ensures NextGen Share is meeting the highest data privacy and security standards. So what is a direct message? Well, it's not an email, but it works in the same way. It's a secure SMTP, or a simple mail transfer protocol. The address would look like an email, but have @direct.nextgen.com after it. And this is what is used to exchange health information through NextGen Share. So why are people using NextGen Share? NextGen Share doesn't just ensure you aren't participating in information blocking. It also satisfies MU Modified Stage 2 requirements, allows better communication between physicians, which means increased care coordination for patients, and decreases manual data entry where possible errors can be made. So for meaningful use Modified Stage 2, the interoperability-focused objectives include Objective 3, use CPOE for medication, laboratory, and radiology orders directly entered by any licensed healthcare professional who can enter orders into the medical record per state, local, and professional guidelines. And with this, you will need to set up an ERX with SureScripts, install a lab interface for results via Rosetta, and also install a radiology interface for results via Rosetta. It also includes objective number 5, the EP who transitions their patient to another setting of care or provider of care, or refers their patient to another provider of care, provides a summary of care record for each transition of care or referral. And with this, you will need to set up NextGen Share, so it is integrated into the EHR in the referral template and medical summary utility. And finally, it includes Objective 10. The EP is actively engaged with a PHA or CDR to submit electronic public health data in a meaningful way using CEHRT, except where prohibited and in accordance with applicable law and practice. And with this objective, you will need an immunization export interface via Rosetta and/or a syndromic surveillance export interface via Rosetta, and some type of NextGen clinical registry service, depending on what your practice is attesting to. NextGen has released a list of registries that clients may register their intent with for the 2015 Meaningful Use reporting period. Testing and implementation dates are to be announced, and pricing is based on what each registry charges. NextGen also had this table in one of their recent presentations showing all of the connectivity environments and examples of each that NextGen supports, which I included for your own personal reference. And finally, the most recent news regarding NextGen and interoperability has been the announcement that NextGen has connected to the Mass Highway, marking the opening of a new secure electronic communication channel for healthcare providers in Massachusetts. The connection makes it possible for clients who use NextGen Share to exchange patient information with more than 350 organizations connected to the Mass Highway, the statewide health information exchange. NextGen came out in a statement saying, "The direct messaging connection between NextGen Healthcare and the Mass Highway clearly demonstrates our commitment to enabling the uninhibited exchange of patient data and reaffirms our commitment to data fluidity. Through the deployment of NextGen Share, we are lowering the barriers to data interoperability and the cost to do so, thereby creating the necessary communication channels to circumvent data blockers while complying with state and federal privacy laws." So ensuring interoperability and fighting against information blocking are not only a top priority for the healthcare industry, but for NextGen and Attentive as well. We at Attentive are very passionate about this subject, and we are working very hard with EHR systems and other exchanges in order to make this a reality. We are looking at new and alternative methods of exchanges, such as telemedicine and population health and portals, to help make information blocking a thing of the past. So I want to thank you all for listening. We're now going to actually go ahead and open up for any questions.
Hi, Lindsay. Thank you so much. That was a very thorough presentation. So before we get to questions, and again, you may enter questions in the webinar control panel. Just type them in and I'll be happy to read them out loud and we'll answer them. But before we get to your questions, I wanted to share a comment that somebody sent over during the presentation earlier, saying we have both HIV treatment and mental health treatment with primary dental care, but run into many barriers with data sharing due to the services we provide. We are unable to provide good quality care for our HIV and mental health patients if other providers won't share the data or accept our data. And then she went on to ask, is this potentially based on individual state law, and would it be considered information blocking?
So to answer that, to go off that, one of the main challenges that the Government Accountability Office pointed out in their report was varying state law based on privacy and security, and also patient consent to share information. So especially since that's such sensitive information, a lot of that could be contributing to, yes, the varying state laws. But on top of that, to consider that information blocking, there is a lot of limitations in identifying information blocking. It's very case by case. So if you do suspect it, you should report it. But just to go off that, I mean, they request a lot of information such as vendor contracts and things like that they don't have access to. But if you do think it's information blocking and not just a case of state laws getting in your way, I would go ahead and contact the OIG or the ONC and see what they could do if they could investigate a little bit further.
Thanks, Lindsay. Okay, next question. Are there new interoperability standards agreed upon by the EHR vendors mandatory for everyone? And if so, what date must they be compliant by?
I can grab that one as well. So the new interoperability standards that I mentioned, they're not mandatory. They're voluntary for each EHR vendor. But they were created by 12 of the leading EHR vendors in the industry today. So to name some of these vendors, think of Allscripts, Cerner, Epic, Athena Health, and of course NextGen. So there is a very good chance everyone will be on the same page following the same standards very soon, but no, as of now, they are not mandatory.
Thanks, Lindsay.
And to go back,
go ahead.
I wanted to answer that first question again, just to be a little bit more thorough on if anyone out there is wondering if someone is committing information blocking and how they would report it. So yes, it is hard identifying information blocking, and it is case-by-case specific. So it needs to follow all three of those facets of that definition, so the knowledge, the interference, and the no reasonable justification. But if you do still suspect information blocking is occurring, you should report it to the ONC or OIG. And you can do that. There is an online form, I believe, and I know there's a hotline. And they'll look into the fraudulent behavior. But just so you know, if you do contact them, what's likely to happen is they'll start an investigation, and then if you're found to have either violated the federal kickback statute, which I mentioned the OIG released earlier, or any type of fraud, then they'll be punished accordingly.
Thanks, Lindsay. Next question. Will entities need to have a business associate agreement in place with every entity they share with?
I can take that one too, Jeannie. Sorry. Yes, I believe so. Absolutely. That's just for, that's actually under HIPAA and high tech as well. We're actually having a webinar on that in 2 weeks, so we can go into more detail with that. But yes, especially to protect yourself to share that information, definitely have an agreement in place.
Okay, great. Well, at the moment it looks like that might be all of the questions, but we're going to hang on for a few more minutes in case people are typing some right now. Otherwise, you can see Lindsay's information up on the screen. Feel free to reach out to her with any questions. I'll be sending an email out later this week that has a link to the slides and the recording, so you can feel free to just reply to that, and you'll reply to me, and I'd be happy to get those questions answered as well. Follow us on social media, ask us questions on Facebook, Twitter, any of that. We're here to help. So truly, if you think of anything after the presentation, you're like, oh darn, I wish I would have asked, just ask us. That's what we're here for. So thank you everyone for sharing your day with us, and hope you have a great one. Lindsay, thank you for the presentation. Jeannie, thanks for being on. Sorry we didn't have any questions for you.
Yes, thank you everyone for attending.